Impressions. This presentation has been prepared by Musayev Emin, Dosent of Ortopedik Dentistry Department. Impression techniques in complete denture. Extraoral examination, non-fitting upper denture, oral cavity of toothless patient, intraoral examination. Prominent maxillary tori. Introduction. Impression, a negative replica of copy in reverse of the surface of an object. An impression can also be defined as an imprint of the teeth and adjustment structures for use in dentistry. Complete denture impression. A complete denture impression is a negative registration of the entire denture bearing, stabilizing and border seal areas present in the edentulous mouth. Preliminary impression. A preliminary impression is an impression made for the purpose of diagnosis or for the construction of a tray. Mexican impression, making primary impression using alginate. Basic requirements for impression making: knowledge of basic anatomy, knowledge of basic reliable technique, knowledge and understanding of impression materials, skill, patient management. Objectives of impression making: retention, stability, support, aesthetics, preservation or remaining structures. Retention. Retention is defined as the ability of denture to resist the displacement against vertical forces. Factors affecting retention: anatomical factors, physiological factors, physical factors, mechanical factors, muscular factors. Factor affecting retention: anatomical factors, size of the denture bearing area, quality of the denture bearing area. Physiological factors, factors affecting retention, saliva and its quality. Factor affecting retention: physical factors, adhesion, cohesion, interfacial surface tension, capillarity and capillarity attraction, atmospheric pressure and peripheral seal. Adhesion: it's the physical attraction of unlike molecules. It acts when saliva sticks to the denture base and to the mucous membrane of basal seat. Adhesion is achieved by ionic forces between charged salivary glycoproteins and surface epithelium or acrylic resin. Quality of adhesion depends on close adaptation of denture, size of denture bearing area, type of saliva. The most adhesive saliva is this series but contain some mucous component. Thick and ropey saliva is very adhesive but tends to build up so that it's too thick in palatal area and interferes with oral adaptation. In this situation, patient should rinse out the ropey saliva every 2 to 3 hours. The amount of retention provided by adhesion is directly proportional to the area covered by denture. Mandibular dentures cover less surface area than maxillary prosthetics and therefore are subject to a lower magnitude of adhesive retentive forces. Similarly, patients with small jaws or very flat alveolar ridges cannot expect retention to be as great as can patients with large jaws or prominent alveoli. Cohesion. It's the physical attraction of like molecules for each other. It occurs within the layer of fluid, usually saliva, that is present between the denture base and the mucosa. Normal saliva isn't very cohesive, therefore most of the retentive forces of denture mucosa interface comes from adhesive and interfacial surface tension factors. Interfacial surface tension, it's the resistance to separation of two parallel surfaces that is imparted by a film of liquid between them. It's dependent on the ability of the fluid to wet the rigid surrounding material. If the surrounding material has low surface tension, as oral mucosa does, fluid will maximize its contact with the material, thereby wetting it readily and spreading out in a thin film. If the material has high surface tension, fluid will minimize its contact with the material, results in formation of bead on the material surface. All denture-based material have higher surface tension than oral mucosa, but once coated by salivary pellicle, their surface tension is reduced, which promotes maximizing the surface area between liquid and base. Role of surface tension is through capillary attraction or capillarity. When the adaptation of denture base to mucosa is sufficiently close, the place filled with a thin film of saliva acts like a capillary tube in that the liquid seeks to increase its contact with both denture and mucosal surface. It plays a major role in retention or maxillary denture. It's totally depend on presence of air at the margin or of liquid and solid contact. Liquid-air interface. As there is excess saliva along the lower border of mandibular denture, surface tension is lost in mandibular denture due to loss of liquid-air interface at denture border. Mucostatic dismiss, adhesion, and cohesion as factors in retention, the entire phenomenon being attributed to interfacial surface tension. But an analysis has provided that if it wasn't for the forces of adhesion and cohesion, the forces of interfacial surface tension won't exist. Attachment of the denture is possible because both teeth and denture-based material can become wet, which means its molecule will adhere to water molecules. Oral and facial musculature. Supplement retentive forces provided. A. Teeth are positioned in neutral zone between the cheeks and tongue. B. The polished surface of the denture are properly shaped. Atmospheric pressure. Act to resist dislodging forces applied to the denture if the denture have an effective seal around their borders. Retention due to atmospheric pressure is directly proportional to the area covered by the denture base. In function, atmospheric pressure is superior to interfacial surface tension as a retentive force for forces horizontal as well as parallel to the mean on mucosal plane are resisted. Interfacial surface tension will resist only forces perpendicular to the axis of surface tension forces. Factor affecting retention. Mechanical factors: undercuts, retentive springs, magnetic forces, denture adhesive, suction chambers, and suction discs. Factors affecting retention. Muscular factors. The muscles apply supplementary retentive forces on the denture. It's most effective in the natural zone. Factors affecting stability. Vertical height of the residual ridge, quality of soft teeth covering the ridge, occlusal plane, quality of the impression, teeth arrangement, contour of the polished surfaces. Support. It's the resistance to vertical forces of mastication and to occlusal or other forces applied in a direction towards the basal seat. Unfortunately, they were never means to endure to forces of mastication and other constant occlusal pressures that result from swallowing, clenching, or brushing. To make the best of bad situation, it's necessary to change the available support to utilizing maximum coverage of all usable ridge-bearing areas. Areas of support are divided into primary, secondary, slide. Primary support area of edentulous ridge that are at right angle to occlusal forces and usually don't resorb easily. Maxillary, posterior right ridge, flat areas of the palate, mandibular, buccal shelf zone area, posterior ridge, pear-shaped pad. Secondary supporting area of edentulous ridge that are greater than at right angle to occlusal forces, also the area of edentulous ridge that are at right angle to occlusal forces but tend to resorb under load. Maxillary, anterior ridge, hook and all ridge slopes, mandibular, anterior ridge and all ridge slopes. Aesthetics. The thickness of the denture flanks is one of the important factors that govern aesthetics. Thicker denture flanks are preferred in long-term edentulous patients to give required labial fullness. Impression should perfectly reproduce the width and height of the entire sulcus for the proper fabrication of the flanks. Preservation of remaining structures. The one stated that the preservation of that which remains is of utmost importance and not the meticulous replacement of that which has been lost. Impressions should record the details of the basal seat and peripheral structures in an appropriate form to prevent injury to the oral tissues. Impressions. Classification. Depending on theories or of impression making, mucostatic, Homeostatic or passive impression, first proposed by Richardson and later popularized by Harrier Page. The impression is made with the oral mucous membrane and the jaws in a normal relaxed condition. Border molding isn't done here. The impression is made with an oversized tray. Impression material of choice is impression plaster. Retention is mainly due to interfacial surface tension. The mucostatic technique results in a denture which is closely adapted to the mucosa of the denture-bearing area but has poor peripheral seal. Mucocompressive impression, Carol Jones, records the oral tissues in a functional and displaced form. The material used for this technique include impression compound, waxes, and soft liners. The oral soft tissues are resilient and thus tend to return to their anatomical position once the folds are relieved. Dentures made by this technique tend to get displaced due to the tissue rebound at rest. During function, the constant pressure exerted onto the soft tissues limit the blood circulation, leading to residual resorption. Selective pressure impression, Boucher. In this technique, the impression is made to extend over as much denture-bearing area as possible without interfering with the limiting structures and function and rest. The selective pressure technique makes it possible to confine the forces acting on the denture to the stress-bearing areas. This is achieved through the design of the special tray in which the non-stress-bearing areas are relieved and the stress-bearing areas are allowed to come in contact with the tray. Depending on the technique, open mouth, closed mouth. Open mouth impressions. The open mouth impression is built in a tray which carries the impression material of choice into the desired contact with the supporting tissues and into an approximate relation to the peripheral tissues when the mouth is opened and without applied pressure. The rationale behind this method is that the dentures don't dislodge when subjects to beating force. The open mouth methods provide clearance for the tissues that are pulled over the edge of the dentures as in function of speed. It develops a contour of impression surface which is in harmony with the relaxed supporting tissues and which may be out of perfect adaptation with these tissues when the denture is subject to occlusal loading. Closed mouth impression technique. This requires wax occlusal rims to be fabricated on the preliminary cast. The patient is made to close off these rims and a generous clearance is made for the various frenula so that the patient can manipulate his tissues by closing, grimacing, sucking, and swallowing to form peripheral borders. Depending on the tray type, stock tray, custom tray. Type of tray. Some dentists use a stock tray and an impression material such as alginate impression plaster or impression compound is used. However, such impressions are generally overextended and serve as primary impressions. Edentulous stock trace. Edentulous stock trace from maxillum and mandibulum. Edentulous stock trace from maxilla and mandible. Two and 3 millimeter clearance required between the tray and the tissues. On casts made from this primary impression, special custom trays are fabricated. The tray is tried in the mouth and modified, and the final impressions are made using zinc or zinc oxide, eugenol, or other such materials. Depending on the purpose of the impression, diagnostic, secondary, primary. Diagnostic impression. The negative replica of the oral tissues used to prepare a diagnostic cast, used for study purposes like measuring the undercuts, locating the path of insertion, is made as a part of treatment plan and to estimate to the amount of pre-prosthetic surgery, articulate the casts on tentative jaw relation and evaluate the interarch space. Primary impression, preliminary impression. An impression made for the purpose of diagnosis or for the construction of a tray. There should be at least 5 mm clearance between the stock tray and the ridge. The tray should extend over humeral notch and maxillary tuberosity. Mandibular tray should cover retromalar pad. Tray can be extended using modeling wax. Impression compound, alginate impression plaster. Herbs appliance. Fitting of individual spoon on the maxilla according to herbs. Red color, white opening of mouth, green color, retraction of cheeks, blue color, pulling the lips out, pink color, correction according to line. Herbs tests fitting of individual tray or mandible. Red color, mouth opening, green color, swallowing, blue, pulling the lips out, purple color, licking the lower lip, pink color, emphasis of tongue on the cheeks, blue color, hold the tongue over the upper red lip border. Adjustment of individual tray with the herbs tests on mandible. Adjustment of individual tray with the herpes test on maxilla. Individual trays mounted with orthocore before placing into oral cavity. Making of individual tray. With some materials. Functional impression taken with the help of repeat zinc oxide eugenol mass, silicon. Reference points on head for determination and forming of prosthetic plane. Occlusal plane should be parallel to the laryngeus line. Determination of head of relative physiological rest. Reference points are being marked on vestibular surface of rim. Secondary impression, wash impression, involve fabrication of custom tray, border molding, developing the posterior palatal seal, making the wash impression. Secondary impression, wash impression, involve the same, depending on the material used. Impression techniques. Impression techniques may be classified depending on amount of pressure used: pressure technique, minimal pressure technique, selective pressure technique. Based on the position of the mouth while making impression: open mouth, closed mouth. Based on the method of manipulation for border molding: hand manipulation, functional movement. Open mouth technique, made with tray held by dentist and mouth open. Muscle movements may be emphasized and can be seen by the operator. Closed mouth technique. The rationale being this technique is that the supporting tissues are recorded in a functional relationship, required occlusal rim to be made, border molding done, and final impressions made. Hand manipulation. Dentist uses hand manipulation for movements of lips and cheeks. Functional movements. Patient makes functional movements such as sucking, swallowing, licking, and grinning. Steps in making an impression. A preliminary examination of the patient, seating the patient, selection of the tray, selection of the material, making impression primary, border molding secondary. Preliminary examination of the patient. A complete case history and through clinical examination is done. Factors that can complicate impression making are identified. Patient education. Seating of the patient. Position of the operator for maxillary impression. Position of the operator for mandibular impression. Selection of tray. The beginning of good impression started with the selection of the correct stock tray. Tray is a device that is used to carry, confine and control impression material while making an impression. The space available in the mouth for upper impression is studied carefully by observation of the width and height of the vestibular spaces with mouth partly one, and in the lower the general form and size of basal seat is studied. Impression procedures. First technique, border molded special tray. Preliminary impression. An edentulous stock metal tray that is approximately 6 mm larger than the outside surface of the residual ridge is selected. The borders of the stock tray are lined with a strip of soft boxing wax, so a rim is created to help confine the alginate material. The objective is to obtain a preliminary impression that is slightly extended around the borders. The tissue surface and borders of the tray, including the rim of wax, are painted with an adhesive material. The loaded tray is positioned in the mouth. The tray is left in the mouth for 1 minute after the initial set. The impression is removed and inspected to ensure all basal seat as included. The impression is poured in artificial stone. Primary impression making with alginate, maxillary. Mandibular impression with alginate. A wax spacer is placed within the outlined border to provide space in the tray for final impression material. A custom tray made using self-curing acrylic resin. Preparing the final impression tray. Border molding is a process by which the shape of the borders of the tray is made to conform accurately to the contours of the buccal and labial vestibules. It begins with manipulation of the border tissues against a moldable impression material that's properly supported and controlled by tray. Border molding. Mandibular border molding. Stick modeling compound is added in sections to the shortened borders of the resin tray and molded to a form that will be in harmony with the physiologic action of the limited anatomic structures. The final impression material is mixed according to manufacturer's directions and uniformly distributed within the tray. Secondary impression. Mandibular secondary impression. Second technique, one-step border molded tray. A material that will allow simultaneous molding of all borders has two general advantages. The number of insertions of the tray for maxillary and mandibular border molding is reduced. Developing all borders simultaneously avoids propagation of errors caused by a mistake in one section affecting the border contours in another. The requirements of such a material are that it should have sufficient body to allow it to remain in position on the borders during loading of the tray, allow some pre-shaping of the form of the borders without adhering to the fingers have a setting time of 3 to 5 minutes. Retain adequate flow while the tray is seated in the mouth. Allow finger placement of the material into deficient parts after the tray is seated. Not cause excessive displacement of the tissues of the vestibule. Be readily trimmed and shaped so excess material can be carved and the borders shaped before the final impression is made. The following procedure utilizes polyether impression materials for border molding. Place adhesive for polyester impressions on the borders of tray. Express a 3-inch strip of polyester material from large tube onto a mixing bag. Next, express 2.5 inches of catalyst to provide sufficient working time to complete border molding. Thoroughly mix material for 30 to 45 seconds using a metal spatula. Position the polyester material on the borders, making certain that a minimum width of 6 mm exists on inner portion. Quickly pre-shape material to proper contours with fingers moistened in cold water. Place the impression tray in the mouth. Inspect all borders to be sure that impression material is present in the vestibule. Border molding is done. Remove tray when impression material is set. Examine border molding to determine that it's adequate. Preparing the tray to secure the final impression. Reduce the borders on the tray that protrude through the polyether. Remove any material that extended internally within the tray more than 6 mm. Remove the relief plugs. Reduce the thickness of labial flank to approximately 2.5 to 3 mm from one buccal frenum to another. Make the final impression in silicone, metallic oxide paste or rubber base. Third technique, custom tray design based on previously worn denture. The denture is treated like a standard impression and a stone cast is poured. An acrylic resin tray is made on the cast over a wax spacer that is outlined just short of the borders of the impressions. The tray is tried in the mouth and cheeks for overextensions. The spacer is removed, relief holes prepared, and adhesive is applied, and an impression is made in the preferred material. Occlusion in complete denture prosthodontics. Introduction. Occlude means to close. The static relationship between the incising or masticating surfaces of the maxillary or mandibular teeth or tooth analogs PT6 GPTH. The act or process of closure or of being closed or shut off. Any contact between the incising or masticating surfaces of the maxillary and mandibular teeth. Occlusion is an important factor which governs the retention and stability of the complete denture in vivo. Occlusal concepts: balanced and non-balanced occlusion, incisal guidance and candular guidance. Occlusion: the act or process of closure or of being closed or shut off. The static relationship between the incising or masticating surfaces of the maxillary of mandibular teeth or tooth. Articulation. The static and dynamic contact relationship between the occlusal surfaces of the teeth during function. Terminology. Centric occlusion, eccentric occlusion, maximum intercuspation, exclusive movement, balancing side or non-working side, balancing interferences. Centric occlusion, the occlusion of opposing teeth when the mandible is in centric relation. This may or may not coincide with the maximal intercostal position. Centric occlusion, an occlusion other than centric occlusion. Maximum intercuspation, complete intercuspation or opposing teeth independent of condylar positions. Exercise movement, movement occurring when mandible moves away from maximum intercuspation. Balancing side or non-working side, the side of mandible which moves during median line during lateral excursions. Balancing interferences under cerebral contacts occurring on balancing side during lateral movements. Adverse case to normal dental occlusion consists with 6K. K1 molar relationship, K2 crown angulation, K3 crown inclination torque, K4 rotation, K5 tight contacts, K6 curve of spine. K2, K3 and K4, K5 and K6. Jaw movements. Only the mandibular arch moves. A working lateral protrusive movement equal towards the side that the mandible moves towards. Non-working mediotrusive balancing movement, not the side that the mandible moves toward. Protrusion equal moving the mandible forward in an anterior-posterior plane. Retrusion moving the mandible backward in an anterior-posterior plane. Mandibular movement, for example. Other case, the up and down motion of the mandible is a combination of two movements. Next, This is mandibular movement protrusive variant. And Bennett movement. During lateral excursion, the bodily shift of the mandible in the direction of the working side was first described by Bennett movement, by this author. The angle formed in the horizontal plane between the pathway of the NW condyle, the mandibular translation, and the sagittal plane is called the Bennett angle. Difference between natural and artificial occlusion. Natural teeth and artificial teeth. Principles of occlusion for complete dentures. Initial and complete occlusal contact in centric relation called centric occlusion. All anterior and posterior denture teeth inclines and surfaces must function as a unit during exclusive movements. Any prematurity must be eliminated. Posterior denture teeth contact with protrude. Anterior tooth contact is contraindicated in centric occlusion. Occlusion for complete dentures. Balanced occlusion consists bilateral simultaneous anterior and posterior occlusal contact is in centric and eccentric positions. 2. Monoplane occlusion positioned in a single plane. And 4. Lingualized occlusion. The maxillary lingual cusp with the mandibular occlusal surface in centric, working and non-working mandibular positions. Selecting the occlusal scheme. Anatomic tooth, semi-anatomic tooth, non-anatomic tooth. Concepts of occlusion. Balanced occlusion, anatomic balanced, semi-anatomic balanced, non-anatomic balanced, lingualized balanced. Non-balanced occlusion, monoplane occlusion. The conventional monoplane, natrocentric concept, and lingualized non-balanced. Balanced occlusion, anatomic balance, semi-anatomic balance, non-anatomic balanced, and lingualized balanced. Non-anatomic balanced. Compensating curve, tilting the second molar, placing the balancing ramp. Factors influencing balanced occlusion. Hanau's guint, condylar guidance, incisal guidance, occlusal plane, compensating curve, inclination of the cups. Concepts of occlusion. Unlike natural teeth, the artificial teeth act as a single unit. Hence, there should minimum of 3 contact points, usually 1 anterior and 2 posterior, for the even distribution and stabilization of denture at any position of mandible. Complete denture occlusion varies with type of the teeth selected. Anatomic teeth should be arranged in balanced occlusion, and non-anatomic teeth should be arranged in monoplane occlusion. All the occlusal forms should have third contact in centric relation. All the occlusal forms are based on different concepts of occlusion, which are spherical concept of occlusion, organic concept of occlusion, and nitrocentric concept of occlusion. Spherical concept of occlusion presenting by Monson in 1920. An ideal curve of occlusion in which each cusp and incisal edge touch the surface of an imaginary sphere 8 inches in diameter. Monson proposed that lower teeth moves over the surface of the upper teeth as over the surface of the sphere with a diameter of h 20 cm. The center of the sphere is located in the region of glabella, and surfaces of the sphere passes through the glenoid fossa along the articulating eminences. Organic concept of occlusion and nitrocentric concept of occlusion. Sears axioms of complete denture occlusion. Ideal requirements of complete denture occlusion. Stability of the denture and its occlusion when the mandible is in both centric and eccentric relations. Balanced occlusal contacts and locking the cusps mesodistally so that the denture can settle down when there is ridge resorption. Functional lever balance should be obtained by vertical tools to reach crest relationship. Cutting, penetrating, and shearing efficiently of occlusal surface. Minimal area of contact. Clearance during posterior functions. Sharp ridges, cusps, and sluice ways to increase masticatory efficiency. Occlusal schemes requires it to fulfill the requirements. Occlusal schemes has three requisites: 1. Incisive units, 2. Working units, 3. Balancing units. Occlusal schemes have been classified into nitrocentric occlusion, lingualized occlusion, non-anatomic occlusion, monoplane occlusion with balance, linear occlusion, balanced occlusion. Balanced occlusion. The bilateral simultaneous anterior and posterior occlusal contact of teeth in centric and eccentric positions. It's not seen in natural dentition. And then characteristical requirements of balanced occlusion. Importance of balanced occlusion. General consideration for balanced occlusion. The wider and larger the ridge and the teeth closer to the right, the greater the lever balance. Wider the ridge and narrower the teeth buccolingually, greater the balance. The more lingual the teeth are placed in relation to the ridge crest, the greater the balance. The more centered the force of occlusion anterior-posteriorly, the greater the stability of the base. Types of balanced occlusion. Occlusal balance or balanced occlusion can be classified as follows: unilateral balanced occlusion, bilateral balanced occlusion, protrusive balanced occlusion, lateral balanced occlusion. Bilateral balanced occlusion, protrusive balanced occlusion, lateral balanced occlusion. Concepts proposed to attain balanced occlusion. Gies's concept. He proposed the first concept towards balanced occlusion in 1940. He suggested arranging 33-degree anatomic teeth could be used under various movements of the articulator to enhance the stability of the denture. Then French concept and Suisse concept. And other concepts. Nine factors governing the articulation are called as Gannot's laws of articulation: horizontal condylar guidance, compensating curve, protrusive incisional guidance, plane of orientation, buccolingual inclination of the tooth axis, sagittal condylar pathway, sagittal incisional guidance, tooth alignment, relative cusp height. Hanau later condensed these 9 factors and formulated 5 factors which are commonly known as Hanau's quint: condylar guidance, incisional guidance, compensating curves, relative cusp height, plane of orientation of occlusal plane. Other concept, Trapazzano concepts by author Trapazzano, and Boucher's concept. Lott's concept, and Bernard-Levin's concept. Factors influencing balanced occlusion: inclination on the condylar path, incisal guidance, orientation of the plane of occlusion, cuspal angulation, and compensating curve. Condylar guidance, recorded from the patient using protrusive registration. The interocclusal records are transferred to the articulator and then accommodated to glide freely into position. Component of horizontal guidance: anterior guidance, incisal guidance, defined as influence of contacting surfaces of maxillary and mandibular teeth during mandibular movements. Plane of occlusion or occlusal plane, compensating curve, two types, anterior-posterior compensating curve, lateral compensating curve. Curvus P consists anterior-posterior compensating curves. Posterior teeth separation when the curve of SP not incorporated. Incorporating the curve SP will provide posterior tooth contact during protrusion. Lateral compensating curves. Compensating curve to Monson curve for Monson curve. Wilson's curve, pleasure curve, reverse curve, and cuspal angulation. Nature-centric occlusion. Nature-centric occlusion is at the far right of the occlusal spectrum and the exact opposite of the anatomic occlusion was developed by Divan. Divan coined the term nature-centric to embody the two case objectives of his occlusal scheme: the neutralization of inclines, the centralization of forces which act on the basal seat when the mandible is in centric relation to the maxilla. There are 5 elements in this occlusal scheme: position, proportion, pitch, form, number. position, proportion, pitch, form and number. Lingualized occlusion concept was introduced by Alfred Giese in 1927. A lingualized occlusion can be defined as a form of denture occlusion that, where the maxillary lingual cusps articulate with the mandibular occlusion surface in centric working and non-working mandibular position. Lingualized occlusion. A lingualized occlusion can be a type of bilaterally balanced occlusion schemes. Anatomic teeth are used in the maxilla opposing a flat cusped or shallow cusped mandibular tooth. Forces directed toward lingual side. Maxillary lingual cusps articulate with the mandibular central fossa. Elimination of contacts on the buccal cusps in both centric and eccentric. The aim is to provide greater masticating efficiently and the elimination of lateral interference. Maxillary lingual cusps firmly contact bilaterally simultaneously. Working excursion, balancing excursion, lingualized occlusion shouldn't be confused with placement of the mandibular teeth lingual to the ridge crest. And monoplane occlusion. Sear introduced monoplane occlusion with balancing ramps or tools at the distal part of the mandibular arch which comes in contact only in eccentric excursion. Divanes used the same principle without the balancing ramp. According to this concept, teeth which are flat mesiodistally and buccolingually are used oriented as close as possible, parallel to the maxillary and mandibular mean foundation plane. Monoplane articulation, teeth setting. No overbite would cause tilting. Overjet of 2 mm is used to create an illusion of overbite. Excursions may or may not contact on balancing sides. Monoplane articulation. Monoplane occlusion without condylar influence. Indication. Conclusion. Many occlusal schemes have been proposed over the years. Most schemes, when correctly used, gives satisfactory results. The result is satisfactory if the patient gets better function, aesthetics and comfort without any adverse changes in denture foundation.